Hi everyone, this is Dr. Chestnut. This is part of the High Yield Radiology series. It probably won't be next year because I've given this lecture to the first years during their anatomy class, but you guys didn't have it, so I'm going to go ahead and put it in here just in case you want it. This is medical imaging anatomy of the abdomen. Now, we're not going to talk a lot about pathology in this presentation. That's going to be on the high yield imaging of the abdomen and pelvis, which is also, should have given you the link to that to your YouTube. So if you're looking for pathology, that's where you go. If you're looking for just imaging of the abdomen, this is where you want to be. So let's get going. So let's talk a little bit about the abdominal radiograph. Now, you might think that the abdominal radiograph is useful in the same way that the chest x-ray is useful for diseases of the chest, but that's not really the case. We get a lot less information from the abdominal radiograph about diseases of the abdomen than we do from the chest x-ray about diseases of the chest. That's not to say that it's not useful in certain cases, and we'll go over some of those cases here in a minute. Now, the abdominal radiograph is also called a KUB, and you'll hear that from your attendings, probably more than abdominal radiograph. They'll say, let's order a KUB on Mrs. Smith in room 420. And when they say KUB, that means abdominal radiograph. KUB stands for kidneys, ureters, and bladder. And you would think that with a name like kidneys, ureters, and bladder, that it would be fairly easy to see kidneys, ureters, and bladder on the abdominal radiograph. But that's not the case at all. In fact, KUB stands for the area in which the radiograph encompasses, from the top of the kidneys to the bottom of the bladder, and including the course of the ureters. It's not that we see the kidneys, ureters, and bladder very well. So what do we see? Well, as far as soft tissue goes, up in the right upper quadrant, you'll see soft tissue that is the liver. And the liver will usually come down maybe a little bit below the ribs, not much in most cases, although sometimes women, for whatever reason, men don't have this, have something called a Rydell's lobe that will hang down as far as the iliac crest. Don't even worry about that. They're not going to ask you that on boards, and they shouldn't give you an x-ray that shows a Rydell's lobe. So if you see an x-ray with a large liver on your boards, then consider it a large liver. But the liver we will pretty much always see up in the right upper quadrant of the abdomen. Something we see far less often in the left upper quadrant of the abdomen is the spleen. The spleen we don't see very much at all unless it's enlarged or unless the patient is very thin. And this patient's pretty thin, so we can see the outline of the spleen in the left upper quadrant. Now, we can see, and you will be able to see this once you get used to looking at x-rays, and I would recommend that anytime you order an x-ray on a patient that you look at them, not only x-rays, but CT scans and ultrasounds and all that, because this way you'll start to train your eye as to what's normal, what's abnormal, and you'll have to rely less and less on your radiologist. Now, relying on your radiologist isn't necessarily a bad thing as long as the radiologist can get it out and get the report to you in a timely manner. But radiologists, believe it or not, are not perfect, and sometimes you can see things that radiologists don't see. And in any case, you're not always going to probably have a radiologist right there on the spot that can interpret your x-ray for you. You may be working in a quick care clinic where there's no radiologist available, for instance. So anyway, look at your own films. And when you train your eye, usually we can see the kidneys, either most or all of the kidneys. And the reason we see those are because the kidneys are outlined with fat. And remember, the fat next to the water density creates that interface. Now, that being said, sometimes portions of the kidneys are obscured by overlying bowel gas or bowel contents. So we can generally see kidneys. It's difficult to see space-occupying masses or cysts on the kidneys unless they're quite large. And certainly we can't really see any intrinsic masses within the kidneys. We don't see the ureters at all. You may see a stone in the ureter, but you're not going to see the ureter. And as far as the urinary bladder goes, we can usually see the urinary bladder if it's filled with fluid, but that's all we're going to be able to see. We're going to be able to see a fluid-filled bladder. And so you can't see a tumor in there because the tumor is water density. The bladder is filled with urine, which is also water density, and you're not going to get that interface. One thing to keep in mind is anytime you see a large mass within the pelvis, particularly in an elderly person, or even sometimes in a child who is already potty trained and is very anxious about not going to, not using the toilet, if you see a large mass, it could be the urinary bladder. It could be something else too, but it could be the urinary bladder. So that's something you always have to rule out. Sometimes we'll just have the patient void, send them to the restroom, have them void, bring them back, shoot another film, and see if that mass is still there. So what is the abdominal radiograph good for? Well, one of the things that the abdominal radiograph is good for is bowel gas. And you can see on this patient, this is the same patient, we can easily see the gas within the stomach, up in the left upper quadrant. Coming out of the stomach, we see the duodenal cap. We can also see gas within the colon. Gas should be in the colon. We want to see gas with the colon, and in this patient we can see some rectal gas. Now what we don't see is gas within the mid portion of the abdomen, within the small bowel, and that's as it should be. We should not see a lot of gas within the small bowel. You might have one or two little specks or what we call loops of gas in the small bowel, but the small bowel shouldn't contain very much gas at all. All right, I wanted to use my red laser pointer on this, but it just screws up the timing for some reason, so I can't do it. But I'll try to describe what's going on. So this is a normal bowel gas pattern. We see gas and fecal material within the right colon and up into the transverse colon, probably some down in the descending colon as well. That's normal. We can have gas and fecal material. In fact, we expect to see gas and fecal material within the colon. We have maybe one or two little pockets of gas within the small bowel. That's also okay. It's not distended. There's not a lot of gas within the small bowel, so one or two loops is okay. Don't get into the trap where you think that any gas whatsoever within the small bowel is abnormal, because it's just not. It has to be quite a bit of gas within the small bowel to be abnormal, like we see here. Now this right image is a small bowel obstruction. What we see is a paucity of gas and fecal material within the colon. Often we don't see any gas and fecal material within the colon. We can if the small bowel obstruction is early, or if it's incomplete. If it's a high-grade incomplete small bowel obstruction, we may still get a little bit of gas through the colon, but there shouldn't be a lot of gas within the colon. What we do see, however, are these multiple distended loops of small bowel air within the center, the upper center of the abdomen. And when we stand the patient up, they have this characteristic, what we call stair-stepping air fluid levels. Those are those straight across lines. And the reason we call them stair-stepping is because it almost looks like stairs that you could just kind of walk up. And this is characteristic with small bowel obstruction. Small bowel obstruction will have a paucity of gas within the colon, multiple dilated loops of small bowel air with air fluid levels on an upright image. So what else can we use the abdominal radiograph for? Well, to look for calcifications, especially urinary stones, like this stone, which is a renal calcification over the lower pole of the left kidney. Almost all renal calculi are calcified And so we have a pretty good track record of seeing urinary calculi. Now, if the calculus is especially within the ureter, it may be difficult to tell whether it's in the ureter or outside of the ureter, and maybe something in the overlying bowel, for instance, or possibly one of the places we see urinary stones a lot is at the ureterovesical junction in the pelvis. But another thing we see in the pelvis a lot are phlebolyths. Phlebolyths are thrombosed, calcified vessels, calcified veins, and those can sometimes be difficult to distinguish. Now, there are ways that or hints that we can use that will help us out, but sometimes it can just be impossible to tell. Gallstones, however, are not usually calcified. Most gallstones are not calcified, and so most of the time we don't see gallstones on x-ray. Sometimes we can, sometimes they'll be calcified, but most of the time they're not. But urinary calcifications usually are. What else we can look for are foreign body searches. Patient may have swallowed something. In this case, this patient looks like he made lunch out of a couple of spoons, a collar stays, maybe a needle, a couple batteries it looks like. Now, you may not have a patient come in with this much, but how about a child who swallows one of those little round watch batteries? Those can corrode through the stomach and can be dangerous. So you might want to find out if the child actually has this metallic density within their bowel and just exactly where it is, so you can point the gastroenterologist or the endoscopist toward it. And of course, there is the ever popular, I was walking through the house naked and fell right onto and you can fill in the blank. In this case, this guy fell right smack onto, I don't know, a ketchup bottle or something. And yes, that ketchup bottle is actually within his rectum. Now, I know a lot of you are laughing here because, I've had you guys in class and other classes like you guys, and I know you can't help but to channel your inner 13-year-old boy and laugh at this, but I guarantee you that if you spend any time at all around the emergency room, you are going to come up with exactly this history given to you by a patient. And we have an epidemic in the United States of people walking around naked and falling right onto things that happen to hit just right to go right into the rectum. And I've seen them all. There is every radiologist has their little collection, light bulbs. I could never understand that. How anyway. But that's another thing that we can use plain radiography for. But the workhorse of abdominal imaging is the CT scan. And that's what we see here. We have an axial or a cross-sectional view of the abdomen. We're in the upper abdomen. If you look at this index image over on the left, I've tried to indicate where we are cutting this CT scan. Now, when we cut through the chest into the abdomen, the first thing we'll see, that this black around the outside here is lung. Okay, when we do when we take a look at the lungs, we can set our settings to either optimize the lung or optimize the other soft tissues. And in this case, the abdominal soft tissues are optimized. So the first thing we see as we cut into the abdomen is the liver. Now, it's not the diaphragm. The diaphragm is very thin and it will lie over the liver. It is almost impossible to see the diaphragm on a transverse image or an axial image. You really need a coronal image to kind of get an idea of what the diaphragm looks like. So we see the liver here. Now, if you'll notice, the liver is primarily within the right upper quadrant, but extends quite a ways over into the left upper quadrant. Now, why is this? I thought the liver was a right-sided structure. And that's true, except that the liver is shaped very much like the state of West Virginia, where it's wider at the top than it is at the bottom. So as we continue to slice through the liver, it will become more and more right-sided as we go down. And I know West Virginia because see that little right angle there where the one vertical thingy sticks up? Right there is where my wife's family is from. They're all hillbillies. And so believe me, I know I have stories for days on them. But anyway, so the liver will take up most of the upper abdomen. Now, over here to the in the left upper quadrant, we see the stomach. The reason the stomach is white is because we give the patient some dilute barium or some contrast drink that has iodine in it. And so if we were to give the patient just water, then it would be dark. But in this case, we have the barium, and so there is that contrast within the stomach. Now, the aorta comes down as it has throughout the descending portion of the aorta in the thoracic region, medial or lateral to the midline on the left side of the spine. So the aorta is very close to the spine, but to the left of midline. In the chest, the esophagus is to the left of the aorta, or to the right of the aorta, but as it comes into the abdomen and through the diaphragmatic hiatus, the esophagus will pass in front of the aorta at the gastroesophageal junction. Now, one thing I want you to note is that when we look at these images, the radiologist will go ahead and put lung window images on these as well, because there are times that we actually find masses or tumors down here in the lower lungs. In this case, this patient has some infiltrates in the right lower lobe. So always read that first paragraph of your report where we're describing the lungs. Don't just jump forward to the abdomen, because you may miss something important. Okay, we're at the same level. In fact, this is the exact same image that you had before. And what we see up high here are the hepatic veins. And we see the hepatic veins because we've given the patient intravenous contrast, and so that makes the blood white. And when we image during the time that there's portal venous drainage or portal venous supply to the liver, we will see the hepatic veins. Now, the hepatic veins, we can see right here. Here's the left hepatic vein, the middle hepatic vein, and the right hepatic vein. And all of those drain right into the inferior vena cava. Now, the hepatic veins will then dive down vertically within the liver, which will become important for us when we discuss hepatic segments later. Now, this will look exactly the same on ultrasound. Here we see an ultrasound through the liver, and we see the left hepatic vein, the middle hepatic vein, and the right hepatic vein all draining into the inferior vena cava. I liken this to Wile E. Coyote. If I see Wile E. Coyote and those are all clear, then I'm happy with that. Now, one of the reasons I want you to know about the hepatic veins is because the middle hepatic vein, or the hepatic veins in general, delineate segments of the liver. The middle hepatic vein divides the right and left lobe of the liver. It is not the fissure for the ligamentum teres, as we see in the left side of the image, which is, I even see radiologists do this. You know, they see the ligamentum teres fissure, and they will, say something in the liver, anteromedial to that is within the left lobe of the liver. Well, In this case, that's probably true, but you can have something posterolateral and still be in the left lobe of the liver, because that is not the boundary. The middle hepatic vein is the boundary between the right and the left lobes of the liver. Just for your information, this is probably more than you need to know. The left hepatic vein will separate the medial and lateral segments of the left lobe of the liver. The right hepatic vein will separate the anterior and posterior segments of the right lobe of the liver. But the only thing you really need to know is that the middle hepatic vein separates the left and right lobes of the liver, so that if you have to give a report to a surgeon about where that tumor is, you can tell him, at least give him a general ballpark idea if it's in the left lobe or the right lobe. So now we're just a little bit lower in the abdomen. We're still pretty high up, as you can see, first of all, by the index image, but also because posteriorly, we have the black lungs. Now, in the right upper quadrant and extending over the left side, over onto the left side, once again, it's the liver. The liver pretty much dominates the upper abdomen. But now posteriorly, in the left upper quadrant, we're starting to see spleen. The spleen is whiter than the liver on this image. That's abnormal. The liver should be as white or whiter than the spleen, but this liver, remember what's a little bit darker than water density, is fat, and this liver is becoming fatty replaced. We'll talk about that in the pathology section. Between the liver and the spleen is the stomach. The stomach now doesn't have that white stuff in it because we've not given contrast, iodinated contrast or barium. What we've done is we've had the patient drink some water, and so that's water in the stomach, and that's a perfectly good contrast material on CT scan. Now, these little slips of muscle posteriorly are the diaphragmatic crura. Crura is plural, crus is singular, and these are just the leading edge of the diaphragm. This is what's going to attach to the posterior abdominal wall to separate the abdomen from the thorax. Running down just to the left of midline, adjacent to the vertebra and retrocrural, or posterior to the crura, is the aorta. Now, to the right of midline and anterocrural or precrural, surrounded on three sides by the liver, is the inferior vena cava. Okay, so now we're a little bit more inferior within the abdomen. As you can see, we're pretty much out of the lungs. And still, within the right upper quadrant is the liver, and the liver started to pull back from the left side a little bit. In the left upper quadrant is the spleen. You can see how the spleen and liver are overlaid by ribs there, and so it's kind of easy to see how if someone fractures ribs, that those could poke right into the liver and spleen and cause splenic lacerations. Now, between the liver and the spleen is the stomach, and again, the stomach has the white stuff in it. That's positive contrast. That's probably barium in this case. Looks a little too dense to be just iodinated contrast. We're starting to see a new structure now in the left upper quadrant, and that's the kidney. Look how medial the kidney is. People oftentimes don't really realize how medial they are. Also, look how bright it is. The kidney concentrates the radiotracer to excrete it, and so the kidneys during this portal venous phase of contrast will be the brightest, or they will be probably almost as white, if not as white, as the aorta. Speaking of the aorta, here it is again retrocrural, just to the left of midline, and precrural to the right of midline, surrounded on three sides of the by the liver, is the inferior vena cava. The inferior vena cava doesn't look as bright as it did on our last exam. That's just because of the phase of contrast, just because the timing is a little different. Now, there's another organ we're seeing up here, and those are the adrenal glands. The adrenal glands have kind of an inverted Y shape or a wishbone shape. And this is a normal appearance of the adrenal glands. Okay, now we're a little bit more distal in the abdomen. We're going to talk a little bit about the portal veins. Remember, the portal veins the portal vein is formed primarily between the confluence of the splenic vein and the superior mesenteric vein. It does receive some blood from the inferior mesenteric and some of the gastrics, etc. But if you look in this, coming out of the spleen, we have the splenic vein. Okay, the splenic vein then drains into the portal vein. Now, look at the shape of this. I always thought this looked kind of like a spermatozoa. For the more squeamish of you, you may think of it as an apostrophe. But the portal vein then will run primarily horizontally and branch into right and left portal veins. Now, this is actually really, I should be saying the hepatic portal vein, because portal vein is not a name so much as a description. A portal vein does not drain directly into the heart via the venous system. It drains through a bed of capillaries, and the hepatic portal vein is one of only two portal veins in the body. The other is in the hypophyseal system, in which there is a portal system. But anyway, so that's a portal vein. Remember, the hepatic veins ran more vertically within the liver. Well, the portal veins run more horizontally within the liver. And I want you to look at this spermatozoa, or this comma here, and right lying anterior, just draping right over that, is the pancreas. Now, the great thing about the portal venous system, or the portal vein and splenic vein in the pancreas, is it looks exactly the same on ultrasound as it does on CT scan. And here you can see the tail of that spermatozoa, the splenic vein, running right into the portal vein. And here you see that kind of spermatozoa, or that apostrophe look. And look at the tissue draped right over the top of that, and even wrapping around the portal vein, and that's the pancreas. It took me the longest time to be able to see the pancreas on ultrasound, but if you find that splenic vein, find that portal vein, find that whole system there, then the pancreas is laying right over top of the splenic vein and will wrap around. The head of the pancreas wraps right around the portal vein. Now, I have mentioned a couple times that the hepatic veins run more vertically, and the portal vein runs more horizontally in the liver. And the reason that's important is because we can divide the liver by segments by the hepatic and portal veins, where they run. This is very important for surgeons, for surgical planning. If they're going to have to resect a portion of the liver, they need to know where a tumor is, how much of the liver they're going to have to resect, what segments they're going to have to resect. It's also important for prognostic information in patients with cancer within the liver, how many segments and which segments are related to their prognosis. But again, here's the hepatic veins running vertically, the portal vein running horizontally. Now, I don't care at all, and I don't think they're going to care on your board examinations if you know the segments of the liver. This will be important if you go into surgery, some sort of general or abdominal surgery, or if you go into radiology. But even then, to tell you the truth, I didn't memorize these things. I had them stuck up on a bulletin board above my workstation, so I didn't have to waste my brain cells memorizing them. There is, however, one particular segment of the liver that you should know. That's segment 1. You don't need to know it's segment 1, but what you may know it as is the caudate lobe. The caudate lobe is not actually a real lobe because it's not enveloped in its own fascia, but it's contiguous with the right lobe of the liver, but separated from most of the right lobe of the liver by the inferior vena cava. Now, the special thing about the caudate lobe, or the unique thing, is it does not drain into the hepatic veins. The blood drainage does not drain into the hepatic veins. They have their own special drainage directly into the inferior vena cava. Now, why is this important? because there is a disease process we call Budd-Chiari syndrome, in which the hepatic veins become obstructed. And so what happens in that case is most of the liver cannot drain, and so the liver becomes congested. It eventually becomes fibrotic and loses function. And so what happens then is that caudate lobe, since it's not drained by the hepatic veins, is unaffected by Budd-Chiari, and so the caudate lobe will actually hypertrophy or increase in size in order to take over the function that's lost by the rest of the liver. So what you see, and we'll discuss this more in the pathology portion, but what you see is fibrosis of the liver with the exception of the caudate lobe, which will be hypertrophied. Now, a term you'll hear used is porta hepatis. Porta means doorway or portal. Hepatis, of course, means liver, so this is the doorway to the liver. And it's not actually a structure, it's more of a region, and it's a region that things pass through. Specifically, passing through the porta hepatis is the portal vein, the common bile duct, also hepatic arteries, nerves, and some lymph nodes. And as a matter of fact, because a lot of blood drains through the portal venous system, in fact, pretty much all the portal venous system gets blood supply from pretty much all of the GI tract. So these lymph nodes in the portal venous system are often the first lymph nodes we see with GI, see that are enlarged with GI cancers or GI, problems, cancers or infections or whatever. So this is an area we really look at very closely for enlarged lymph nodes to see if there may be metastatic disease, to see if there may be some sort of a GI infectious process. Okay, this is what everybody hates. I'm not sure why. I think people, first of all, probably not used to looking at it. But second of all, I think they make it into something more complicated than what it is. But that's the biliary ductal system. And this is the a retrograde or an endoscopic retrograde cholangiopancreatography. In typical medical fashion, we shorten that to ERCP. Although if you drop endoscopic retrograde cholangiopancreatography on your family at Thanksgiving dinner, they'll probably be very impressed and are likely to think that, yes, you may truly be a doctor someday. So anyway, what we've done is we've put an endoscope down the person's esophagus, through the stomach, into the duodenum, and cannulated the major papilla. Then we've injected contrast backwards or retrograde through the biliary system in order to visualize the biliary system. So what we see within the liver are a number of intrahepatic ducts, and these will drain bile, from those hepatic lobules that we've already talked about. So the intrahepatic ducts will drain bile into either the right or left hepatic duct. So that's simple enough so far, right? Intrahepatic ducts drain into the right or left hepatic duct. Where the right and left hepatic ducts join, they form the common hepatic duct. Anytime you see the word common, that means it receives tributaries from two or more sources, or it branches into two or more branches. Now we see another structure here over kind of on the right, and that's the gallbladder. This gallbladder contains a number of stones, but the gallbladder is a cystic structure. In fact, when we take out the gallbladder, we call that a cholecystectomy. A cyst is just a rounded fluid-filled structure. Chole refers to bile, so this is a bile-filled rounded structure, a cholecyst, and that drains through the cystic duct. So you have bile draining through the cystic duct, you have bile draining through the common hepatic duct, so where those join, they form the common bile duct. Okay, so not too difficult. The common bile duct will drain through the major papilla, as will the pancreatic duct. And, they drain through the sphincter vodi, through the major papilla, into the duodenum. Okay, now we're a little lower in the abdomen. How do I know that? Well, for one thing, I don't see lungs anymore. So we're out of the lungs. We see some more of the organs that are down a little bit lower in the abdomen, but we still see the liver over in the right abdomen. The liver will be with us throughout most of the abdomen. Now, in the inferior aspect of the liver is the gallbladder. Remember, the bile system drains by gravity. It doesn't pump bile upwards, it just drains by gravity, and so the gallbladder is naturally going to be on the inferior portion of the liver, so when the patient is upright, gravity will drain the bile. Over in the left upper quadrant of the abdomen, posteriorly, is the spleen. We'll see liver before we see spleen, and we'll see liver after we see spleen, and that's because the liver is a lot larger than the spleen in a normal patient. Again, we have the splenic vein draining into the portal vein, and draping right over the top of that complex and wrapping around the portal vein is the pancreas. Posteriorly and medially are the kidneys. The kidneys are very bright. They're brighter than any of the other organs on this scan, and that's because they're concentrating the contrast in order to excrete it. We see the left adrenal vein, that inverted Y or wishbone shaped. We're already through the right adrenal vein. And just to the left of midline, retrocrural, once again, is the aorta. Now to the right of midline and precrural is the inferior vena cava. As we get higher in the abdomen, the inferior vena cava will start to become surrounded by the liver, but this low, it is not enveloped by the liver. The duodenum will wrap around the head of the pancreas. Remember that for when we get into the barium studies where we're looking at the bowel. And we see some small bowel, and we see colon. Now, I wouldn't expect you to know necessarily always what is small bowel and colon. Colon usually will be more around the outside of the abdomen. Small bowel will be more within the mid portion of the abdomen. But sometimes you just have to scroll through several slices in order to determine what's small bowel. Okay, a little bit more inferior within the abdomen. Once again, we still see the liver. We don't see spleen. We're out of the spleen by this point. We again see the pancreatic head, which is wrapping around the portal vein. That's that kind of bright circle you see just to the left of the pancreatic head. Posteriorly and very medially are the kidneys. Again, the kidneys are very bright, and that's because they're concentrating that contrast in order to excrete it. Now we're through the crura. The crura has already blended with the posterior wall of the abdomen, and so we see the aorta is no longer retrocrural because there's not a crura to be retro or antero. And in the inferior portion of the abdomen, the aorta will move more toward the midline, but still to the right of the aorta is the inferior vena cava. We see here on this study, or on this slice, the renal vein, which if we would scroll up and down, we could see that draining right into the inferior vena cava. We see the duodenum, which will go on to wrap around the head of the pancreas. And in this case, we're seeing a little bit of colon as well. All right, let's talk about the kidneys for the next couple slides. One of the really cool things we can do with our newer helical scanners is do these things called the CT urogram. And what we do with CT urograms is we give the patient contrast. We do a spiral CT scan of the abdomen and pelvis. All our CT scans almost anymore are spiral CT scans. There are very few places that don't do spiral CT scans, mainly third world countries, because most first world countries have sold them their old CT scanners when we're doing spiral CT scans. But anyway, what happens is we tell the computer to only show us structures above a certain density. And because the kidneys concentrate this contrast, they're very bright, they're very dense, as are the bones. And so that's what we're seeing here on this image. And what we see are a very good picture of the kidneys, the ureters, and the urinary bladder. And this is a really nice image in order to look for ureteral tumors Not so much for ureteral stones, because sometimes the contrast can obscure the stone, but for tumors. Here is just a close-up image of the kidney. We get a very nice appearance of the kidney. We see the minor calyx, which, of course, 2 or more minor calyces will drain into the major calyx. The major calyces all drain into the renal pelvis. The minor calyces, the major calyces, and the renal pelvis, we refer to collectively as the renal collecting system, and you'll hear that term quite often. The renal collecting system, or the renal pelvis, drains into the ureter, and at the point where it does is the ureteropelvic junction. Now, notice how the pelvis kind of funnels down into the ureter at the ureteropelvic junction. This is why this is a good place for stones to get caught, because there can be a stone that's large enough to rattle around the renal pelvis, but is not large enough to go through the ureter, and so this funnel right here is where it gets caught. And just that blush in the kidneys is due to All right, here's a very nice ultrasound appearance of the kidney. The kidney is one of the more distinctive things that we see on ultrasound of the abdomen. This happens to be the right kidney. How do I know that? Because I see the liver running right over the top of the kidney. Now, the kidney has this very characteristic ovoid or sort of a bean-shaped appearance, and on the outside is the renal cortex. The renal cortex is dark. It should be probably a little bit darker than the liver. But the reason is because, remember, if you slice open a kidney, that cortex is very homogeneous, and so there's not a lot of interfaces for that ultrasound to bounce off. That's opposed to the fat within the medullary portion of the kidney, which is because fat, if you'll remember what it looks like under a histologic slide, there's all those bubbles, all those interfaces for sound to bounce off, so fat is bright. Now, notice what we don't see on the normal kidney, and that's the renal collecting systems. The only time we see the renal collecting system or the ureter is if there's an obstruction. And in this case, what happens is urine backs up and causes hydronephrosis. Hydro means water, nephrosis means kidney, so hydronephrosis, water in the kidney. It's just urine distension of the renal collecting system. Hydroureter would be urine distension of the ureter. And so what we see on this patient with hydronephrosis is we see, again, that dark renal cortex. We do see some of that medullary fat, although the fat's compressed and is less noticeable than before. But since water is, or urine being almost totally water, is very easy for sound to travel through. It's going to be black. And so the black stuff in the middle is the renal collecting system. And we see the renal calyx, which drains into the renal pelvis, and that is going to drain into the ureteropelvic junction into the ureter. The fact that this kind of really funnels down there and I don't see a dilated ureter means this is probably your ureteropelvic junction obstruction. All right, here is the dreaded blood supply of the abdomen. Of course, the main artery that supplies the entire abdomen and the pelvis is the abdominal aorta, again running just to the left of midline, down the abdomen, down the posterior abdomen. The first major branch off the abdominal aorta is the celiac trunk. Now, we don't see the celiac trunk on this angiogram because it's coming straight out at us. And so the celiac artery is lost within the opacification of the aorta. But the celiac then branches off to the left into the splenic artery. The splenic artery is typically very tortuous. This is really the first artery that you'll see in the body that calcifies with atherosclerotic disease. I don't know why, probably because it is so tortuous. To the right, we have the common hepatic artery. The common hepatic artery will then split into the gastroduodenal artery, which, as you might expect, will supply much of the stomach and the duodenum, and the proper hepatic artery, which will supply the liver. The next major branch off the aorta is the superior mesenteric artery. Of course, this is going to supply All of the small bowel and most of the large bowel, we'll see more of that on the next slide. Just below the superior mesenteric artery are the renal arteries, the right and left renal arteries. You can tell where the renal arteries are because if you follow them out, you can see the kidneys start to concentrate that contrast just like it does in CT. It's getting blood supply from those arteries and concentrating that radiographic contrast. And then the last branch off the aorta is going to be the inferior mesenteric artery. The inferior mesenteric artery, of course, will supply the remainder of the colon. And I said that was the last branch. That's really not, because what happens is the abdominal aorta then branches into the right and left iliac arteries. Okay, here we have a couple more selective angiograms. For the previous one, what we did was we put a catheter up within the high aorta, probably the high abdominal aorta or the low thoracic aorta, squirted contrast in, and let it run out through all those arteries. What we've done here with this left angiogram is we've put a catheter right into the superior mesenteric artery. And so what we see is the superior mesenteric artery, and that branches off into several arteries that will supply the colon. That'll be the middle colic artery, the right colic artery, and the ileocolic artery. The ileocolic will supply the cecum and portions of the inferior right colon and the terminal ileum. And one of the nice things about these arteries is that they are named for what they supply. We also see the superior mesenteric artery supplies the entire small bowel. And so it will supply arteries to the jejunum and the ileum. Now on the other side, we've done a selective angiogram of the inferior mesenteric artery. The inferior mesenteric artery supplies the distal third of the transverse colon, the entire left side of the colon, and the rectosigmoid colon. And again, they're named pretty much for where they go for the most part. So branching off the inferior mesenteric artery, we have the ascending branch of the left colic artery. If you see an ascending branch, then you're probably going to have a descending branch. So that's the descending branch of the left colic artery. Now there's an anastomosis called the marginal artery of Drummond, and you'll see that throughout the bowel. This is so that if one of those arteries becomes obstructed, the bowel can then get flow from the other arteries that will supply that portion, and that works more or less some of the times. For the sigmoid colon, the sigmoid arteries. All right, so far we've talked a lot about the solid organs of the abdomen. We haven't spent a lot of time on the hollow viscera of the abdomen, the stomach, the small bowel, and the large bowel. And basically the reason is because up to now we haven't really been looking at modalities that are really very good for looking at the hollow viscera. By the way, I love this image because when you get into surgery, or if you do some radiology and look at barium studies, this is just what you think about the small bowel. It's just anarchy in there. So this study should look fairly familiar because we looked at it early in this discussion. This is plain radiographs, and we saw on the plain radiographs there was a limited number of things that we could do, and one of the things we could look at is bowel gas. And we compared a normal bowel gas pattern versus a small bowel obstruction, and so plain radiography is pretty good for looking at small bowel obstruction. What it's not good for is looking at things within the bowel, things extending from the bowel. We can see that there's a bowel obstruction, but we can't see what's causing the bowel obstruction. So plain radiography is quite limited in evaluation of the bowel. CT scan is an improvement over plain radiography. We can tell what's going on in the bowel wall. For instance, in this case, there's thickening of the wall of the colon, and this is right at the level of the cecum. If we look at this on a coronal image, we see this thickening of the wall of the colon. This happens to be a colon carcinoma. So it's better than plain radiography, but it's still, we can have trouble looking at things within the lumen of the bowel. We can have some trouble looking at things extending off the bowel and looking at the bowel gas patterns as well. So no matter how high-tech we get, there are times when we keep coming back to old standbys, and this is a technique that we've used for decades, and that is to have the patient ingest or to infuse barium into the patient and take radiographs with barium in the patient. You can see that this guy is really enjoying his meal of barium. That's kind of a typical appearance. I had a professor once, or an attending once, when I was at Children's Hospital in Boston, that when he would skip lunch, he'd drink one of these cups of barium. He said it has no calories. It would just go right through you. It would fill you up, and it didn't taste that bad. Now, pediatric radiologists in general are a little bit strange anyway, and I've not ever felt the desire to replace lunch with barium. But anyway, the thing is, barium doesn't taste that bad. We can flavor it, and we do. Most of it's flavored kind of mint flavored, which just is disgusting. But we can flavor it with chocolate, we can flavor it with strawberry, but it's not the taste that people object to so much, it's the consistency. And this is an image from an upper GI exam where we've given the patient barium. What we do generally with these is we give them some crystals that release carbon dioxide within the stomach. It's basically like taking Alka-Seltzer. We give them those with just a little bit of water because we don't want a lot of fluid in the stomach because that will cause the barium not to stick. But that'll expand the stomach. These patients always feel like they have to belch, and we try to keep them from doing that. Then we have the patient drink barium. We roll them around while we're looking in real time under fluoroscopy and take various images and watch the barium as it travels through the stomach. And so what we see here, this is an outline of the stomach. Now it's not really expanded. This guy has probably belched up a lot of that carbon dioxide, but it gives you a good idea of the anatomy of the stomach. So the upper portion of the stomach is, above the level of the gastroesophageal junction is the gastric fundus. Now where the kind of below and on the medial upper margin of the stomach is the gastric cardia. The body of the stomach is everything else until we get to this gastric antrum. And if you think antrum is an entryway, or it's a foyer before an entry. So an antrum of a building is where you first enter that building. And the passageway that you're getting ready to go through is the pylorus. And the pylorus is that channel between the stomach and the duodenum. This is what, in hypertrophic pyloric stenosis, this is what is obstructed. Now, on the medial aspect of the stomach is what we call the lesser curve, and more laterally is the greater curve. And just think, if you were to draw a line along the lesser curve and draw another line along the greater curve, the lesser curve would be smaller than the greater curve, thus the name. All right, I showed you these images on this slide during the congenital disease of the GI tract, but this is a normal duodenum. Now, this is part of the upper GI barium study, and what we've done is, the contrast has come out of the stomach, it's passed through the pylorus and passed into the duodenum. The duodenum makes a loop that looks very much like a C. We call that the C loop of the duodenum, quite naturally. Now, I told you before in CT scan, remember that the duodenum wraps around the head of the pancreas. Well, that's what's happening here. The pancreatic head fits right into that C loop, and the old-time radiologists would look for changes in the C to look for pancreatic enlargement, pancreatic tumors and stuff. That was, before they had CT scan. But anyway, the duodenum comes around and goes up, crosses midline, and attaches to the ligament of Treitz in the left upper quadrant of the abdomen, at least as high as the stomach and behind the stomach. If it doesn't do that, such as in this case where this duodenum didn't really go across midline, it certainly doesn't attach up in the left upper quadrant of the stomach, that's malrotation. And malrotation is a condition that can lead to volvulus, intestinal volvulus, which can be extremely serious and even fatal. So this is a small bowel barium study, and what we've done is we finished with our upper GI examination, and much to the patient's chagrin, we've had them drink even more barium, and we follow that with sequential abdominal radiographs until the barium gets all the way through the small bowel and into the colon. And what we see is first coming out of the stomach is this duodenum with its C loop where the pancreatic head fits. The duodenum then crosses the midline, goes up to at least as high or higher than the inferior aspect of the stomach, and attaches in the left upper quadrant of the abdomen by the ligament of Treitz, and this is where the duodenal jejunal junction is. Now, we don't see the ligament of Treitz on barium studies or on CT scan, and that's why it kind of, as a purist, sort of bugs me when people say, well, here's the ligament of Treitz. No, here is the duodenal jejunal junction. We just know that the ligament of Treitz attaches there, and that's important that the ligament of Treitz does attach there because this helps prevent malrotation and midgut volvulus. So beyond the duodenal jejunal junction, coming down primarily within the left abdomen, tending over toward the mid portion of the abdomen, is a jejunum. And notice the kind of feathery, fluffy appearance of the duodenum and jejunum. We call this a feather boa pattern, much like the feather boa that the Hulk is wearing here, always fashionable. And what this is for is these are folds within the duodenum and jejunum in order to increase surface area and absorb nutrients. Now, there is no point where we can say the jejunum stops here and the ileum starts here. It's more of a longer transition, but the ileum is within primarily the right abdomen, and the ileum doesn't have near as many of these folds. It doesn't look like that feather boa because most of the nutrients that we've needed to absorb have been absorbed by now, so it doesn't need all that increased surface area. And then, of course, the ileum dumps into the cecum, which is the first part of the colon. Now, there are differences in the mucosal pattern of the small bowel and the large bowel. In the small bowel, as we see in the left side of the image, has these plica circularis or valvulae conniventes, and these will extend all the way across in a continuous line across the small bowel, like you see here. It's kind of like a slinky. Whereas the large bowel have haustral markings. Now, the haustra are not in order to increase surface area. What happens is we have this Taenia coli, which is a fibrous tissue that runs along the colon, and it's not as long as the colon. And so these haustra are just pleats or accordions, where this Taenia coli has accordion the colon. And the distinctive things of the haustra is the folds do not extend all the way across the colon. They only extend about halfway across the colon because of this Taenia coli. All right, so if the patient didn't like his upper GI and small bowel follow through, he's certainly not going to like the way we evaluate the colon. You can't really do a good antegrade study of the colon because you can't dilate or distend the colon well enough. And so we do this retrograde. We put a catheter into the rectum, we blow up a balloon within the rectum to hold that catheter in place, and then we infuse barium through the catheter. We also have a little hand pump that we use to pump air in, and we'll turn the patient as we use this air in order to both dilate or distend the colon and to push that barium column around. And we turn the patient and all over the place to get the have gravity help us get barium to flow around. It's quite a production. It takes a little bit of technical. It takes having done it and having been trained in a little bit of technical skill. I always kind of liked it because of that, and I always liked to try to make the patients as comfortable as I could during it, but the patients still didn't like it very much because it's an uncomfortable examination. But what we see here, first of all, is we see the haustra. Now, remember the haustra are the mucosal folds within the colon, and they don't continue all the way across. You see that little strip there, which is the Taenia coli. The terminal ileum is the distal portion of the ileum that empties through the ileocecal valve into the cecum. This is where a lot of disease occurs. If you're going to have Crohn's disease, chances are it's going to be here at the terminal ileum. About 90% of Crohn's patients has terminal ileal disease. This is also the most likely place small bowel lymphoma is going to occur, and so we really like to get a good look at the terminal ileum, whether it's on the barium minima or on the small bowel follow-through. Now, extending off the colon off the cecum, the tip of the cecum, as a blind-ended tubular structure is the appendix. Now, the Latin name is vermiform appendix. Vermiform means worm-like, and that's exactly what this looks like. This looks like a night crawler you could chop off and go fishing with. The first portion of the colon then is the cecum. The cecum dumps into the ascending colon. It's called the ascending colon because it ascends up the right side of the abdomen. Then it goes up and makes this turn and empties into the transverse colon, goes up and makes another turn into the descending colon. And where that descending colon, when it crosses the iliac crest, it becomes the sigmoid colon. The sigmoid colon will then empty into the rectum. Now, where this makes these turns, we call the flexures, and up in the right upper quadrant is the hepatic flexure. And you might hear a radiologist say that there's a mass in the ascending limb or the descending limb of the hepatic flexure. In the left upper quadrant is the splenic flexure. The splenic flexure is usually higher than the hepatic flexure because you don't have the liver pushing down. The spleen's a lot smaller than the liver. Okay, so that's basically it. One thing that you might do, I know you guys don't have much else going on right now. You have a lot of free time, but when you're done with your studying, just for grins and giggles, you can go to this site and just scroll up and down through a CT scan. And I would recommend that when you order CT scans on your patient, that you do that. You maybe get a radiographic atlas next to you and scroll up and down the CT scan and start learning all these different organs, where they are. Radiopedia is a great source. It's Radiopedia spelled the British way, .org, not .com. Although if you put in .com, it'll flip you over to Google, and Google will say, did you mean .org? But you can enter the search engine, and one of the good things about Radiopedia is it has a lot of normal studies, and so which is usually one of the things that's lacking on the interwebs. So, good luck. Probably now that you're done with this, the next step should be to take a look at the High Yield Radiology of the abdomen and pelvis, in which we put our anatomy use that we've just studied to practical use in looking primarily at pathology.